Hi everyone. You know when you get really nervous because you're about to talk in front of people and you're doing all of your square breathing like Dave taught us on day one and it's not working. And you know the flight or fight response, you're choosing flight right about now. That's how it's working. Uh, I wanted to make sure that I had my telephone turned off. For those that are younger than 35, my iPhone or inferior Samsung device. Turned off and onto silent, so I stuck it in my pocket. My wife just texted me to wish me luck, and it wobbled in my pants pocket, and I genuinely thought I was having a stroke. So I'm not having a stroke, so this is good, but I'm in the right room for it. Look, my name is Rob Timmings. There isn't, I don't think, a bio in the conference paperwork, so most of you will probably confuse who I am with this guy. Totally different. Absolute connoisseur of the coffee, but that's not me. Many of you, again, those in the under 35 age group will probably know me from my social media exploits. That said, long before TikTok was ever a thing, I've been playing in the Facebook space because that's where grown-ups go. I don't do a lot on Instagram, which I understand is just like Facebook, but for people who can't read. So TikTok is where it's at, and most of my education that I do, the little snippets of talks that I do, is in that TikTok space. I don't dance and I don't do come get ready with me's, but again, if you're under 35 and you're on TikTok, you'll know exactly what that means. I wanted to talk to you today about the lethal triad. Trauma is something that I have been very passionate about teaching into as a nurse educator for the best part of 25 of my 36 years as a nurse. I trained at the Royal Brisbane Hospital as a nurse and then later went on and did some academic studies. I now live and reside in Queensland at Bribie Island and for Bribie Island, which is just a little bit north of Brisbane and a little bit south of the Sunshine Coast, but we try to say that we live in both places at once. That's Bribie Island. We were on the map just very recently because of the cyclone that had us right on point. So that was pretty exciting. But my background is an emergency nurse and teaching into rural and remote emergency practice. I'm a dad. I'm a husband. I'm a nurse. I'm a woodworker. I love my fishing, and I like both kinds of whiskey. Those that know. I'm also really enjoying Thailand. This is my first time to Thailand. So I'm trying to learn the language one word at a time. So I've noticed how many different terminologies have Thai on the end of them. So this is the one that will put apparently blood on your face if you sit too close in the audience, from what I understand. Muay Thai. Who's found this at the 7-Eleven? Hong Thai. This is my new crack. Uh, Think Vicks, but it's in a tea bag. It's not oily. It's amazing. You sniff on it and it clears your sinuses. It clears pretty much any of your plumbing. It's called Hong Tai. There it is. Chang Tai, of course, Chang means elephant. This is the other Chang Tai, and I've really been enjoying a few of those Chang Tais. Totally different type of Chang Tai. This angel that was on our opening night drinks, who lined up behind the pad thai that was being made right in front of us. That was fantastic. So, yeah. So I'm liking everything about Thailand. Most of it's food related. This is a bit of a stretch, my Thai, but it will come up a little bit later on when we talk about the lethal diamond. No Thai. So why the lesson in jargon? You've only got to be working in the world of trauma and emergency for 5 minutes to realise how much jargon we actually have to wrap our head around. And for all intents and purposes, that jargon tends to use terms that may have one or two different words that mean exactly the same thing, or two words or two terms that sound very, very similar that mean something completely different. Examples, hypoxia and hypoxemia, as just one small example. Trauma is full of jargon, and I thought that we should start with a little bit of jargon to unpack this concept that is called the lethal diamond? First of all, can I see a show of hands of those who aren't familiar with the concept of lethal diamond? Thank you. Thank you. A show of hands for those that aren't familiar with the concept of the lethal triangle, the triad of death. Yeah, okay. Thank you. So I would almost hazard to guess that those that put their hand up the first time who haven't heard of the term lethal diamond have probably heard, just from the show of hands, have probably heard of the lethal triangle. The difference between a diamond and a triangle is just one more side, and ultimately that is that we've changed the terminology. The lethal triad that we've had for so many years has now become the lethal diamond because we've added an extra element to it, and ultimately that's what this presentation was going to look at. So where does it start from? I think we have to go back a little bit and have a look at mortality in trauma. We know that if you're going to die from your traumatic injury, 80% of those who die in trauma will die in the first 4 hours. About 80%. If you're going to die, 80% of you are going to die in the first 4 hours. Which means the other 20% of you who do die will die in a delayed peak, in a delayed death. It won't happen in the car before you get cut out. It won't happen in the emergency department when you're brought into the ED necessarily. It may not even happen on the operating theatre or in the intensive care after you've gone through the system and got yourself through damage control. But it may happen in that third peak, what we call the third peak of death. And that third peak of death, we see that as almost an M-shaped peak, a dichrotic notch. There is a very definite peak of time at around about the 3 to 5 day mark where people will die from complications of their trauma. And then another peak at around about that 3 to 5 week mark. So somewhere between that 3 to 5 days and that 3 to 5 weeks, we see that 20% who will die from their trauma ultimately will die in that space. Now, in the world of emergency, I think that I think I would be fair to speak on behalf of you and say that we play in the immediate peak and we play in that classic golden hour, which isn't an hour, it's about 4 hours, but let's just, so that we're not stepping on toes and getting all pernickety or persnickety about time, let's just talk about that second peak up to around about that 4 hours. The immediate deaths, these are the injuries that are incompatible with life. There is nothing that we could have done for that patient. We arrived on scene and it was a decapitation or an exsanguination or an injury that was just incompatible with life. There was nothing that we could have done. If that same crash had happened in the driveway of a major metropolitan trauma unit with an operating theatre staff fully equipped and fully ready to go, there was no way we're going to save that patient. They're your immediate deaths. We can't do anything about that. Governments reduce those numbers. Governments put into play strategies like drink driving campaigns and wear a seatbelt or you're a bloody idiot. Those sorts of campaigns. Yep. Speeding. So where we play in the second peak of death. From the moment that we arrive on scene, we're protecting an airway, we're protecting breathing, we're protecting circulation, we're looking after the D for disability, we're looking after all of that ABCD or CABD, or put it into whatever order you want, because nobody seems to be able to make their mind up as to where the highest priorities are, but to say that primary assessment's our highest priority, irrespective of which letter of the alphabet you start. And while we're all running around tripping over each other, looking after the airway, the breathing, the circulation, the oxygenation, the sedation, the pain relief, protecting the airway of the patient with an altered level of consciousness, while we're tripping over them, what we have tended to do historically in trauma is failed to recognise that there are dark horses that we don't see in our trauma room. And those dark horses were the dark horses that we referred to once upon a time as the triad of death, or the lethal triangle. Remember, everything in trauma fundamentally comes down to play when we talk about the fact that the trauma patient is losing blood. It's blood loss past, it's blood loss present, and it's blood loss future. Our fundamental principles were always airway, breathing, and circulation, A, B, C, and D. The focus on the second peaks now makes it really important that we are ever vigilant of the things that we don't see coming. So this is the lethal triad. This is what we had sort of pre-2020. It probably dates back earlier to that. But pre-2020, if you've been working in the world of trauma for a period of 24 years or 4 years or longer, then you probably will have come across this idea that yes, we're looking after airway, breathing, circulation and disability, but we also need to be mindful that this is a patient who in trauma typically will become cold. They become hypothermic. They drop their pH, they drop their temperature, and this alters their oxygenation. They become hypoperfused as a result of blood loss, and all of that chaos leads to coagulopathy. But that's not the whole story, because in this industry, we tend to keep revisiting. Remember, nothing in science is ever true. Everything in science has always been seen to be improved on or disproven. And ultimately, we understand that there are two rules in our industry. The first one is to never give out all of the information. I'm also not great at the maths. Let me give you all of the information. We're going to add one to it. It's a slow audience. We're going to have a look at hypocalcemia. This was the new kid on the block, hypocalcemia. It was always there. We just perhaps didn't understand it or recognise it as well as what perhaps we should have. So let's take a deep dive into each of the four elements, and then I'm going to let our next speaker speak. So firstly, we'll start with acidosis. We know that a normal pH is 7.4 if we're looking at arterial blood, a little bit less if we're looking at venous blood, and for all intents and purposes, in the throes of the middle of a resuscitative event in a trauma patient, we're probably pulling venous blood more than we're pulling arterial blood. It's easier to access, particularly in the context of working in a remote location. We can pull blood very, very quickly and throw it through a point of care testing device like an iStat. And so if I have a patient who is in a state of acidosis, then I would say that their pH, if it's coming from their artery, is of course going to be below 7.35 and below 7.31 if we're looking at venous blood, which is why the asterisk is against that 7.31 before anyone in the room starts to get upset that the numbers aren't quite what they learned. I'm trying to be a bit inclusive here. So why do we become acidotic? Ultimately, in the context of somebody who has blood loss trauma, we're talking about hypoperfusion. And we can go all the way back to a whiteboard exercise where I can draw a picture of a cell and we can talk about the Krebs cycle and the aerobic metabolism versus the anaerobic metabolism. But ultimately, if I'm not feeding my tissues, my cells oxygen, then my cells will very quickly convert over to an anaerobic metabolic state, and they will start producing large amounts of lactate. Before that happens, though, they're probably going to be starting to produce large amounts of CO2 that they're not able to get rid of if they've got chest injury. So you can see hypoventilation and hypoperfusion is ultimately leading to a state of both metabolic and respiratory or mixed acidosis. Now, red blood cells don't like to carry oxygen when they're profoundly acidotic. So my patient's desaturating in front of me post-blood loss. They're driving their body down into a state of acidosis where pH is lower than it should be. And we see their saturations are sitting in the 80s, 70s and heading south. And the first thing that we will do as clinicians is throw oxygen on that patient's face. And of course, you'd be forgiven for doing that. We all do it. If somebody's desaturated, they need oxygen. There is no question about that. But remember, red blood cells need to want to carry oxygen as well. And they're not wanting to carry oxygen if the patient's in a state of profound acidosis. So the more acidotic your patient becomes, the less likely they will carry the oxygen that you just happen to be strapping on their face. So that non-rebreather at 15 litres a minute, or that nasal prongs at 2 litres a minute, or that CPAP, or that BiPAP, or that ventilation that we're providing for that patient with enriched air, with high concentrations of oxygen, may be falling essentially on deaf ears when it comes to hemoglobin, that is less likely to want to carry it if the patient's profoundly acidotic. So what comes first? Is it acidosis causes hypoxemia, or is it that hypoxemia causes acidosis? And of course, the answer to the question is yes. It's a good question. Hypoperfusion is the main feature that fuels acidosis, that lactate rise. We know that a normal lactate sits south of 1, 0.5 to 1. We start to get nervous when it rises above 1. We're certainly quite nervous when it rises above 2. And when it hits about 4 in certain contexts, like your very sick trauma patient or your very sick sepsis patient, lactate levels of 4 and above can start to then take on a whole new meaning. They become prognostic. The prognostic outcome for a patient who is in septic shock with a lactate above 4 is probably close to about 50% mortality. And that's double what it would be for a standard septic patient that would come in. We've got sepsis rates in my country, in Australia, of around about 27% if we wanted to average that for sepsis. Early aggressive fluid resuscitation is now a thing of the past. This idea that we would take a patient, stick 2 large bore cannula into them when they came in with bleeding trauma, and then just load them with 2 litres of normal saline before we stop to think about what we're doing next. That 2 litres of rapid infusion of normal saline is now a thing of the past. We now have moved into a world where we don't want to over dilute. Because when we start to throw 2 litres of normal saline straight into a patient's stat, not only are we loading them with a large amount of chloride, which is unhelpful, and certainly fuels the hypochloremic acidosis, but it also pretty much dilutes the drink. Ultimately, your blood is a cocktail, not dissimilar to this rum and coke or the Mai Tai that we might have seen earlier. And if you have ever been in a situation where you have donated blood, where you walked into that blood bank with 5.5 litres of blood in your body, you donated 500 mils, half a litre, and then you went to that other little room where some nana gave you a biscuit and a cold cup of tea. If you've donated blood, you know exactly what I'm talking about. You're not allowed to go for 15 minutes, but then after 15 minutes, if you're feeling okay in the head, you're allowed to stand up and you're allowed to leave. Well, you walked in with 5.5 litres, you left half a litre, but you walked out with 5.5 litres of blood. So having left half a litre of blood at the blood bank, just 15 minutes later, your volume has been replenished. Can you see? You have reconstituted your own volume. And this happens with every patient who's compensating when they have large blood loss in trauma. We might see a puddle of a litre of blood or more on the roadside, but they're not a litre depleted. They have reconstituted and they've shifted water from their third space. They've propped up their blood volume to maintain their mean arterial pressure. So they're not volume depleted, they're quality depleted. Yeah. So how do I know my patient's acidotic if I'm not going to take a blood gas on them? Anyone? No trick questions and no trick answers. You can look at saturations, but that doesn't necessarily tell me immediately that the reason for a decrease in saturation is acidosis. I want to thank you for being the first one to speak, though. Thank you. Tachypnea. Who said tachypnea? Right from the back of the room. And that's exactly right. You can pick that somebody is acidotic simply by looking at their respiratory rate. Unless they're anxious and nervous to talk in front of a big group like this, or they have some psychogenic hyperventilation. You know, we call that the Justin Bieber effect. Well, tachypnea or rapid breathing is always acidosis. We've moved on from the 1970s where we believe that carbon dioxide is our driver for breathing. We know that's not the case. We keep teaching it to our young ones. But CO2 levels don't determine what your respiratory rate and depth is. pH does. We know that the dominant driver of your respiratory rate right now, whatever your respiratory rate is in this room right this minute, is determined by your pH. And so if my patient is laying there in a trauma trolley and they have got rapid breathing, I have to assume that this is pH related first, maybe psychogenic second. But this is the first way that we're going to determine. Let's move from acidosis and now have a look at hypothermia. Blood is warmth. Blood's hot. 37 degrees. And when I spill that 37 degrees out into an ambient environment, I lose heat. So if I'm coming into contact with an environment, if my body is in contact with an environment that is at lower body temperature to mine, I'm losing heat through convection. If I've got wind blowing across me and that wind is not blowing across me with a humidity of next to 100% and 37 degrees, that sounds like here, then I'm developing hypothermia. If I have an injury or a trauma that's going to decrease my capacity to neurally send messages to my hypothalamus to regulate and set my thermoregulation, like a high spinal cord injury. We think of those patients with high spinal cord injuries above the level of T6 who become poikilothermic and can't maintain their body temperature. Then these patients become hypothermic. But perhaps the biggest one historically that has caused our trauma patients to develop hypothermia and drop their body temperature has been the mere fact that we used to fluid resuscitate very aggressively with fluids that weren't warm. We would take that 25 degrees Celsius normal saline off the shelf in the trauma room, and we would slap that into that patient faster than we could blink. And that patient was being literally cooled down from the inside from the iatrogenic administration of cold IV fluids. So what did we do during the 1990s and the early 2000s to circumvent that? We started to teach you've got to warm the fluids. If you're going to give fluids quickly, we've got to give fluids warm because we're cooling our patients down. Now, why is that a problem in bleeding trauma? Why is being cold, being hypothermic, an issue in trauma? And there are many, many concerns with being cold, but certainly remember how I said that acidosis is going to inhibit your red blood cells' desire to carry oxygen. Well, cold blood inhibits your red blood cells' desire to give up the oxygen once it arrives where it's going to take it to. So let's assume that my red blood cell has picked up oxygen in the lungs and it's now going to go off to the brain or the kidneys or the heart or whatever tissue that we want to deliver oxygen to. There has to be a relationship with hemoglobin where hemoglobin wants to pick up oxygen, carry it to where it's going to deliver it, and then drop it off and actually release that oxygen at the other end. And we know that we get a shift in that hemoglobin dissociation to the left whenever we've got somebody that's very cold. And for this reason, we need to try and keep the patient as normothermic as possible. But there's one more obvious reason why we want to keep that patient normothermic. And that is because in a bleeding trauma patient, if there's one thing I want my bleeding trauma patient to do, and that is to stop bleeding. And coagulation is a chemical chain reaction. It's a cellular response when we look at clotting, but coagulation in and of itself is chemical. It's a chemical chain reaction. And that chemical chain reaction is made more efficient in a normothermic environment. It's inefficient, it's sluggish, it's slow in patients who get cold. So once my patient drops down below about 34 degrees Celsius, then their ability to be able to coagulate starts to dramatically deteriorate. So all of those little bleeding sites, if they should have a rebleed, stopping that bleed a second time becomes more challenging for this patient who's cold. So keep them warm. Hypothermia can happen not just through blood loss, but also other fluid loss. And when we think about patients with really large burns, that frightening picture of that Dave put up on day one of the patient with the big escharotomy scars, losing. I mean, we're looking at a photo worthy moment, but what we're failing to understand, unless we really dive deep into that picture, is just how challenging his fluid shift would have been, and how much volume he would have lost, and how much heat he would have been losing through those injuries. Muscle relaxants, when given early in trauma patients to secure airways, inhibit things like shivering, one of our autonomic responses to try and maintain warmth. High spinal cord injuries, as I said earlier on, above the level of about T6, can contribute to a form of neurogenic shock, where a hallmark symptom is that poikilothermia, that ability for an animate object to take on the temperature of its surroundings, like a lizard or a snake, becomes as warm as the rock that it's sitting on in the sun. Likewise, your patient in an emergency room or in the back of an ambulance at 22 degrees Celsius becomes 22 degrees Celsius when they have these severe spinal injuries. Coagulopathy was the third in the triangle, the original triangle, and coagulopathy is complex. We talk about coagulopathy and some of the sequelae of having coagulopathy as being trauma-induced coagulopathy and DIC, or disseminated intravascular coagulopathy. Certainly what happens first and far more commonly in our trauma patient with blood loss is trauma-induced coagulopathy. And it becomes a complicated mechanism there that really has two dominant players. One is consumptive coagulopathy, where the patient has injury, they coagulate to try and stop their bleeding, and now because they've used up, consumed all of their coagulation factors, they're now left without coagulation factors, so that if they have a rebleed, they can't stop. So I've used up all of my factor 10 and my fibrinogen and my prothrombin and all of my other coagulation factors, stopping my bleeding early in my presentation. But now my body is going to start to undergo a thrombolytic process, and proteins like plasminogen and activated protein C are going to start to inhibit the clots that I have formed, those very clots that stopped me from bleeding to death there on that road 20 minutes ago. Now I start dissolving those clots. I start breaking down those fibrin bonds, and now I start rebleeding. And of course, when I start rebleeding, I want to try and stop bleeding again, but now I've used up all of my coagulation factors. I have a consumptive coagulopathy. The other is dilutional coagulopathy, and hopefully we're doing less and less of the dilutional coagulopathy now that we've moved away from really high volume fluid resuscitation to a more permissive hypotension model, where I just want to give small boluses of fluid to my patient just to prop up their mean arterial pressure to a number that we're happy to keep their kidneys kicking over with. You know, we talk about 65. I'm not going to be pinned down to what map we should be striving for every patient, but somewhere in the order of 60 to 65, we're generally playing in those numbers. There's nurses in the room that are probably going to cringe and say, no, keep it above 65. But remember, not all patients are one size fits all. So in an attempt to try and keep somebody's fluid resuscitation, maintaining a mean arterial pressure, I should say, then that fluid resuscitation sometimes can cause overdilution of that patient's blood. Remember, they're already somewhat dilutionally impaired when they come into our care, before we even receive the patient. And it's not because of the fluids that the AMBOs have given them. It's not because of the fluids that the doctors and the nurses in emergency have given them. It's just naturally part of that autonomic process of compensation, where the patient will shift body water into their blood to maintain their own mean arterial pressure. All we saw was the bloody mess and thought, crap, this patient needs a whole lot of fluid. Loading this patient with fluid now, what we've done is we've taken a patient that was already probably dilutionally anemic, and we've just made them more anemic. We've diluted out what little red blood cells they had already in their system. We've taken that patient with dilutional coagulopathy and we've made it worse. We've added more water and we've essentially watered them down even further. We've taken their white blood cells that they've lost a lot of because they've had a big bleed, and we've now diluted those as well. So we've got a dilutional, not just a coagulopathy and an anemia, but we've also got a dilutional immunocompromise. This patient's immunoincompetent at a time when we're throwing tubes and pipes and bells and whistles and needles and holes. And I mean, let's face it, folks, I'm among friends here. We stick a needle in a hole in every, a needle and a tube in every hole, don't we? And when they don't have a hole, we cut one. And that's a real challenge to later delayed third peak deaths like sepsis. So let's build a clot. I've cut myself. Sorry about the physiology lesson, but we're just going to go really basic here for us, just for a minute. Let me go down the wormhole. My blood vessels exist and secrete substances on the inside of the walls of their lumen, specifically to regulate the size of the blood vessels to maintain flow, to inhibit clotting formation, so platelets are actively moved along like they're in a no standing zone as blood is travelling through my vasculature, and my coagulation factors made predominantly in the liver floating around in my blood right now. Let's think factor 10, factor 2, prothrombin, and factor 1, fibrinogen. Factor 10's got a fancy name as well. We'll call him Stuart. So we've got Stuart. It's actually called Stuart. I don't know. Stuart Prower factor. Anyway, these three factors are floating along in the blood, doing absolutely nothing, minding their own business. And they're kept dormant by heparin sulfate that is produced by the inside of the lumen of your blood vessel. That glycocalyx layer that lines like a slime on the inside of your blood vessels secrete heparin to keep your blood anticoagulated. So your blood continues to flow. When platelets come anywhere near the walls of your blood vessels secrete prostacyclin to repel those platelets. Almost like if you've ever been to Brisbane Airport or any Australian airport, there's the guy that's in the yellow that won't let your wife drop you off for more than 5 minutes. She's not allowed to get out of the car. You have to do the kiss goodbye in the car. Otherwise, there's somebody that comes along to move them on. You know the person I'm talking about. Well, that's prostacyclin, and that prostacyclin's shooing away platelets. Platelets would be the laziest of our cellular particulate matter in blood, and the moment that a platelet wants to go anywhere near the vessel wall, prostacyclin wants to shoo it away. And the other substance that's secreted from the inside of the vessel wall is nitric oxide, which is our vasodilator. So we've got a vasodilation, keeping your blood flowing. We've got an anticoagulant, keeping your blood flowing. And we've got an antiplatelet agent, keeping your blood flowing. And then we have an injury. And when we have an injury, now that function is disabled. It's disrupted. So naturally, we're going to have a vasoconstriction to cause a reduction in blood flow through that damaged vessel. We're now going to cause a coagulation pathway to be activated, and we're going to cause a clotting pathway to be activated so that platelets can now attend the edge of that blood vessel and start to form a clot. Can you see that vasoconstriction, clotting, and coagulation, collectively we'll call that hemostasis, is a state that is not the norm. That is the state that we compensate to when we have an injury that needs to have bleeding that has to be stopped. Platelets, coagulation factors like prothrombin and fibrinogen, ultimately forming fibrin. And that's that stringy strand of what looks like white cotton matter wrapped around these blood cells. Incidentally, a way of really measuring for coagulopathy in our trauma patient is to look at a bit of an old-fashioned blood result called D-dimer. And D-dimer is this white fibrin that you can see here. Imagine that I took chemically some scissors to that and I chopped up that fibrin into tiny little fragments. It's no longer fibrin, it's what was once fibrin. That's D-dimer. And that for us is a way of determining that this patient has already gone through quite a large coagulation process. They've formed a large amount of fibrin, and if their D-dimer is up and through the roof, then that gives us a good indication that this is a person who has already consumed a large amount of their coagulation factors. and possibly are going to be impaired at being able to reclot should they want to or need to, increasing the importance for us to be able to give them something that's going to be able to build a new clot again, some FFP or some cryoprecipitate. So just a very, very quick lesson on blood, 5.5 litres. It's essentially like a cocktail. It's divided into, about 45% rum at the bottom and 55% Coke at the top. When they bleed, they lose the Coke, they lose the rum, and then of course they reconstitute themselves just up with Coke. It's not the same rum and Coke anymore, is it? And that's the state that they come in. Coagulopathic, hemodiluted. So it leads to hemodilution, which is not dissimilar to this beer that you saw earlier. Um, who's had a Chang? It's a little bit like having sex in a canoe, isn't it? It's fucking close to water. You can edit that bit out on Facebook. Um, so bleeding leads to dilution, and it's not always us. It's usually them. So let's take this Mai Tai, and what we're now going to do is we're going to dilute that Mai Tai. If I dilute that Mai Tai down, if I just topped it up with orange juice, it's not going to have the same flavour. It's not going to do the same job. It's not going to have the same enjoyment. If that Mai Tai analogy was blood, and blood had to carry oxygen with red blood cells, and I dilute that, then I'm not going to be able to carry oxygen as efficiently once it's been diluted. I'm not going to be able to coagulate efficiently once I've already diluted and consumed my coagulation factors. And I'm also not going to be able to maintain my immunocompetence if I've washed out all of my antibodies and my white blood cells. So we get to a situation where this coagulopathic patient, this hemodiluted patient's unable to rebleed, unable to reclot, I should say. Now, a mantra that I learned a long time ago as a very young nurse in trauma, and that is the first clot is the patient's best clot. Their first clot's their best clot. This idea that we don't want to disrupt the clot. So let's talk about the fourth horse in this apocalypse, in this diamond of death. And the fourth dark horse is calcium. We know that blood is full of electrolytes, and calcium is certainly one of those electrolytes. When we bleed a large volume of blood, let's assume for argument's sake I'd lost 1/3 of my blood volume, arguably could say I've lost 1/3 of my calcium, which now when I reconstitute my blood back to normal volume, now I've diluted out my calcium. Calcium is carried in two places in our blood. Functionally, we carry it bound to albumin as a calcium albumin complex, which is inactive, it's unable to be used, and then the free calcium, which is our ionized calcium that's carried just in solution within plasma. Now, when we bleed, we lose calcium, so that's an easy way to reconcile a drop in overall body calcium in a bleeding trauma patient. It was lost because it's been left in the dressing, or it's been left on the side of the road. We also dilute. When we fluid resuscitate, we dilute somebody's calcium, so that further reduces their calcium milligrams per mil, millimoles per mil. When we give blood transfusion products, and the big one is packed red blood cells. When we give packed red blood cells to a patient, there's a sizable portion of citrate, which is an anticoagulant. It's the same anticoagulant that is that little bit of fluid that's floating in the bottom of the blue-topped coag tubes when you send your coags away for analysis. That same citrate is the same stuff that's in the packed red blood cell bag that we give to a patient. So 1 or 2 units of packed cells probably doesn't cause that much of an issue. But once we start to get to 3 or 4 units, certainly within the first hour post arrival, a large massive transfusion type protocol, we're giving not just large volumes of colloid to the patient, but we're giving large volumes of colloids that have been kept anticoagulated with citrate. So you're pouring citrate into your patient at the same time as you're pouring blood in. Now that citrate immediately binds with calcium that's floating in the patient's blood, removing that calcium from being available. So you can see that you get a dramatic reduction in calcium the moment that we start to fluid resuscitate the patient or provide blood products to that patient. So I'm not saying don't give blood products, but what I am saying is that we need to keep a closer eye on our calcium and we need to preemptively strike. We know that when the patient is getting blood transfusion products, that they're going to have a calcium slump, and therefore calcium gluconate is probably needed to be given almost as a pre-med. In certain types of injuries, like severe burns and particularly big crush injuries, when we think of somebody who's had a torso that's crushed, pedestrian versus car, or in an industrial accident where a person is literally crushed between a solid surface, two solid surfaces, muscles and fat release very, very large amounts of phosphates. And phosphates, once they're liberated into blood, also will look for something to bind with. And if there's nothing a phosphate likes more to bind with, then it's a calcium, a doubly positively charged calcium ion. So phosphate and calcium will bind very readily when I have a big release of phosphate from a crush injury or a muscular injury or a large fat injury. Then that reduces further a person's calcium. And of course, coagulation. Calcium is so important to the chemistry of coagulation that we looked at, touched on a moment ago, that it's actually also given another name. Does anyone know what calcium is otherwise referred to in the world of coagulation? Of course you know. Go and shout it out. Factor. So you know there's 13 coagulation factors? Yes, you do. There's 13 coagulation factors. Factor 6 doesn't exist, so that's a pretend one. But factor 4 is calcium. So factor 4, when we talk about factor 4, it's one of our important factors, and it's used in both sides of our coagulation pathway, both intrinsic and extrinsic, or contact and tissue activation pathway. So factor 4, calcium. In hemorrhage, serum calcium falls, blood containing calcium is lost, it's not autonomically replaced. To be able to, where do we get our calcium from in our blood when we need it? We don't go and quickly have a drink of milk or eat some cheese. How do we get our calcium quickly when we need it? Anyone? Yeah, we store it in our bone. Is that going to be sequestered from bone and liberated into circulation quickly? Minutes to hours? No, that takes a long time. It takes days to be able to drag that calcium from bone. The demineralization of bone is probably not also is also not a desirable, but it's certainly not a timely approach. So we need to give that patient calcium. Blood loss causes albumin loss. Remember, albumin is a dominant protein that's floating around inside your plasma right now. When I lose a large amount of blood, I lose a large amount of plasma. And when I lose a large amount of plasma, I lose a large capacity to be able to carry calcium in my blood. A sizable portion of the calcium that's in your blood right now is being carried in albumin, ready to be duck-fed back into ionized form when we need it. So with large amounts of blood loss, we lose large amounts of calcium and the albumin that carries it. And of course, coagulation consumes it. In transfusion, the serum calcium falls because banked blood is full of citrate. We've touched on that. Blood loss causes albumin loss. We've touched on that. And acidosis causes unloading of the albumin calcium. So my acidotic patient's going to release calcium from their albumin proteins in their plasma. That calcium spike's going to be consumed very rapidly by the coagulation pathway, depleting all of the calcium. Can you see they're not just losing it because they're bleeding it, but they're losing it because they're consuming it. That coagulation pathway is consuming that. In crush injuries, it's not just muscle tissue, but also fat saponification that's going to release that phosphate that causes binding. And that's pretty much, ahead of time, has brought me to the end of the 4. So what did we look at? We looked at the ABCs, but being vigilant for those dark horses. It's the coagulopathy, it's the hypothermia, the acidosis, and the reduction in calcium levels in our trauma patients that go on to contribute to poorer outcomes in that third peak, those 20% that die long after they've left our emergency services. And it's high time that we stop and recognise the importance of the dark horses of this apocalypse. I've had fun. I haven't really. Kidding myself. I teach to rooms of 15 people, so this is a little bit overwhelming for me. But I'm happy to take any questions if you're going to be gentle and kind. Any questions for Rob?
We say that this starting to pick up all resources and overly that but when we do come and see I see a lot of critical nervous states that don't
Sorry, say that last bit again. Critic.
How's the people like it's a harmful with that anything I'm seeing.
So, are you specifically talking about bleeding trauma patients? And you see elevations in their phosphate level or a depletion in their phosphate? And calcium's fine for the moment. Okay, so calcium levels are going to drop directly proportional to the amount of blood that a person loses. So think they're not just losing red liquid, they're losing calcium. Yep, number one. So very large blood loss. You'll see a calcium depletion much, much quicker. And almost certainly because of that large blood loss, you've got a large amount of that coagulation pathway being activated to try and stop blood loss. Yeah, the hemostatic process is consuming calcium. So in those patients, you're more expected to see a depletion in calcium quicker. And then even faster again if we're throwing packed red blood cells in on top of them, which is the right thing to do, but recognise that there's always costs and benefits, right? And so if we're going to be throwing packed red blood cells into that patient that's bled a lot with a calcium level that currently is doing okay, it's within reason to expect that we're going to have to watch that calcium level very, very quickly because we're going to see that tank as soon as we start packed red blood cells. Now, as I said, 1 or 2 units of packed cells, so what? But when we're looking at, ploughing in 4 or 5 units, massive transfusion protocols, and I would suggest if you're not a trauma unit, you're probably thinking moving those patients on pretty quickly. But can you see that whole process, that takes time? And for that reason, it would be reasonable to assume that your calcium levels are probably going to be somewhat normalised within that first hour or so. I don't even know if I answered the question. We really just sort of walked through the process, yeah. Alrighty. Any other questions, folks? So, I'm sorry, I missed that. TXA is certainly a game changer, without question. It's probably one of the mainstay treatments inside the first 3 hours, tranexamic acid, and for patients who we have a suspicion that have trauma-induced coagulopathy, TIC, absolutely, without question. So given inside that first 3 hours, the bleeding trauma patient. So for those that are not familiar with TXA, I don't want to ever assume that an abbreviation is something that everybody understands the meaning of. So tranexamic acid, TXA is a drug that we can give to a patient that shuts down and inhibits the thrombolytic pathway. So right now, if you clot, fibrinogen's going to try and break down your clot, right? Plasminogen will try and break down your clot. So plasminogen turns to plasmin and starts chopping away all of that fibrin. That's how we break down our fibrin, fibrinolysis. Tranexamic acid stops that process. So it impairs your natural breaking down your clot cycle, meaning that it doesn't stop you from bleeding. Tranexamic acid is not a cork. in a leaking bottle. Tranexamic acid takes into account that you have been able to coagulate, and now we're going to preserve the clot that you've made. We're going to stop your body wanting to break down the clot that it's made. That's where tranexamic acid comes into play. So to answer the question on whether tranexamic acid has utility early in the blood loss trauma patient, within the first 3 hours, absolutely yes. But in a patient who is completely coagulopathic and now doesn't have any any fibrin floating around, they're not breaking down fibrin anymore. They don't have that plasminogen pathway anymore. TXA is probably not going to do much work because it's looking to disable plasminogen, and if plasminogen's not doing its job, then TXA is essentially redundant. Does that make sense? It made sense in my head, and that's what's important. Question.
To benefit is it then in traumatic wounds that we're packing, so putting TXA so causes the stuff on.
Yeah, you put me under a spotlight because I haven't read the papers on how effective it is TXA soaked dressings. Can I tell you that if you're going to pack a bleeding wound with something that's going to stop bleeding, TXA is probably not my first choice. It would be something that is a clot activator, not something that is a stop you breaking down the clot that you've already made activator. Does that make sense? So I'm allowed to make up my own words because I have the microphone. But so products like Oxycell and look, I'm not wanting to tout brands, but Quick Clot, Combat Gauze, those sorts of products that are impregnated with kaolin, that quite literally are negatively charged ions that hyperstimulate the coagulation pathway to switch on your coagulation. Those products would be my first choice if I was going to use something like that. But I guess we've got to put the cart before we can't put the cart before the horse. Let's not talk about what do we do when the patient's bleeding. TXA is a conversation about the ongoing bleeding patient. What we should be doing is stopping the bleeding right from the get-go. And so that's where our focus is. Damage control surgery and put a hemostat onto the bleeding vessel and diathermy it off or stitch them up or cross clamp. And we